You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is August 18th, 2025. Our topic today is Rhinitis Practice Parameters and Guidelines. This is presented by Dr. Mark Dykewicz. He is a Raymond and Alberta Slavin Endowed Professor in Allergy and Immunology and is the Allergy and Immunology Fellowship Program Director at St. Louis University.
You're ready, you can go. So good morning, everybody. I'm Chris Miller. This is Conferences Online in Allergy. Today is August 18th, and our speaker today is Dr. Mark Dykewicz. He is Professor of Allergy and Immunology at St. Louis University. He'll be speaking to us on rhinitis, the practice parameters and guidelines. And Dr. Dykewicz is one of the authors of the 2020 Rhinitis Update, and he's going to share a lot of good information. And if I recall right, I think we've got a new version coming out in the near future too.
There are other guidelines that will actually be pretty consistent that are coming out shortly that I'll just mention too. So a real pleasure to be with everybody this morning, and I've got no disclosures. We will have as our objectives trying to better distinguish between allergic and non-allergic rhinitis and differential considerations and how that dovetails into our selection of medications particularly. And I will mention somewhat about the process and deliberations that were used in the Joint Task Force guidelines as well as other guidelines that are in development. So this will be a focus on Rhinitis 2020, the most recent Joint Task Force practice parameter update on rhinitis. I would say almost sadly, this came out, of course, when COVID was starting. And so the document, I think, did not always get the visibility, the recognition that it deserves. But it's a very comprehensive document. Many participants joined together to create it. And it is a very comprehensive guideline. It covers not only allergic rhinitis, but I think importantly, non-allergic rhinitis. And that is also of note because several other guidelines that have been in development or have previously been published have been restricted to allergic rhinitis. So there's a lot of non-allergic rhinitis going out there as well. The document's got 37 major recommendations. Several were performed using the grading of recommendations, assessment, development, and evaluation grade approach. And the other ones did have very extensive literature reviews and evidence tables that were underlying them, but those were consensus-based statements. Now, this is just to tell you, if you start going into the document, which is quite lengthy and comprehensive, you can start off, there's a table, what is new or newly emphasized in the document. Now, I will be highlighting in the course of the lecture what some of these key developments were. But as you start going into the document, just be aware there's a table to sort of orient you as to what are the newest things that are being focused. We'll begin, of course, with a definition of rhinitis, a brief mention of its importance. The definition of rhinitis used for this guideline was based upon symptoms, and the cardinal symptoms being nasal congestion, rhinorrhea, which could be either anterior, posterior, sneezing, and or itching. The importance of this, I don't think needs to be stated too much to this audience, but allergic rhinitis is very common, maybe 14 to 20% of the population, depending on what estimates you're looking at, and then is viewed as the sixth most common chronic illness. But chronic non-allergic rhinitis, in adults anyway, can be affecting maybe a similar number of people. There's a lot of impact on quality of life, disturbed sleep, daytime somnolence, leading to depression, impairment of physical and social functioning, learning problems in school, memory deficits, and there's a really substantial economic burden on society, with both people missing work or missing school, or being present in school or work, but with presenteeism not really performing up to snuff. And we also, of course, must recognize that rhinitis is often associated with and potentially can impact asthma, allergic rhinitis, rhinosinusitis, and sleep disturbances. Regarding the types of rhinitis, this was very comprehensively covered within the document. I'm only going to give you the key highlights. First of all, we do have to recognize that when we say itis and rhinitis, and that connotes inflammation, rhinitis can have inflammatory components of certain types, like allergic rhinitis, and some types of non-allergic rhinitis, but for many forms of non-allergic rhinitis, such as vasomotor rhinitis, there's no inflammation involved with it, but we decided to stick with rhinitis as a term. There are some alternative terms like rhinopathy that have been proposed, but have been at least rejected by our group. Just a few words about vasomotor rhinitis. We kept the term, although some would use the term idiopathic rhinitis. In many cases, people can have triggers with temperature and humidity changes, airborne irritants, and strong odors. It really is a diagnosis of exclusion, and the symptoms can be quite variable, ranging from nasal obstruction and clear nasal secretion, versus allergic rhinitis. Sneezing and pruritus tend to be much less common. Cough is commonly associated with vasomotor rhinitis, as with allergic rhinitis. And very brief overview of mechanisms. It probably varies in different subsets of patients, but there certainly is evidence of neural efferent traffic abnormalities in the nasal mucosa, with some imbalance between the parasympathetic and sympathetic nasal innervation. I think one thing we have to realize is that there are a number of differential considerations that can, mimic, if you will, rhinitis. Be mindful that nasal septal deviation is quite common and can cause nasal obstruction. There is the problem of nasal valve collapse, where you have anatomic changes within the nose that are not going to be responding to medications that are going to address the nasal mucosa. And the nasal valve collapse with the structures of the nose can cause airflow changes that can be perceived as nasal congestion. Turbinate hypertrophy is another common problem. The concha bullosa would be where you've got the, if you will, the pockets within the bony structure that lead to increased size of the inferior turbinates. But this can account for severe unilateral or bilateral obstruction and be something that surgery can help address. Also be mindful, a lot of people are presenting with symptoms that overlap with presentation of rhinosinusitis with or without nasal polyps. There could be congenital anomalies in kids. And you can also run into pharyngonasal reflux. GE reflux can play a role. In terms of the diagnostic approach, of course, we're relying upon history, doing a good physical exam, allergy testing if indicated, and sometimes other diagnostic testing is required, such as nasal endoscopy. One thing that we really tried to do was, even though it's a lengthy document, put in a lot of helpful information to help not only with diagnosis and treatment. So we included new tables that assist in making the differential diagnosis for rhinitis based on patient history and also the diagnosis and treatment for other conditions that may mimic rhinitis. And just to give you an idea of what's in there, and there's no way I can really do justice to all the detail in there, but we have tables that, in this case, for instance, are looking at a symptom versus how common it is in allergic rhinitis, non-allergic rhinitis, NAR, acute upper respiratory tract infection, chronic rhinosinusitis without nasal polyps, and chronic rhinosinusitis with nasal polyps. So I've just highlighted, for example, that if you had patients presenting with decreased ability to smell, hypoosmia, or incomplete or inability to smell, anosmia, that's not very common. It's occasionally seen in rhinitis, but is much more common in chronic rhinosinusitis. And if you look down just as another example, eustachian tube dysfunction may occasionally occur with allergic rhinitis and non-allergic rhinitis, but if you have patients with a lot of that going on, you would also think that that's probably not chronic rhinosinusitis. It's more with the ear popping and the ear pressure that you would see that with rhinitis. I think one important thing to do right off the bat is what are the bothersome symptoms, and making a distinction between whether people are being bothered by runny nose, nasal congestion, sneezing, or itching, with itching being less common in non-allergic rhinitis. Now, in many patients, you have associated eye symptoms of itchy, watery, red, and swollen eyes. It's been found that this is more commonly present in allergic rhinitis and more commonly occurs from allergic rhinitis from pollens than house dust mites. Now, this said, I would also make the point that the ARIA allergic rhinitis in asthma group has been doing work that is based, among other things, on patient-reported symptoms. And they have generated data saying that there are some patients who don't have any conjunctivitis symptoms, and they actually may respond somewhat differently to treatments and have somewhat different underlying mechanisms. So why do we take the history? Well, we're trying to figure out the basis for the rhinitis that allows us to help select therapies and also interventions. So we do make use of terms such as intermittent versus episodic environmental, short-term environmental exposures versus persistent. And we use terms such as seasonal versus perennial. Sometimes this helps us in the decision about which medications may be most appropriate. For instance, using a medication that has a quicker onset of action with relatively short-term symptoms. We also, of course, want to look at environmental effects of home versus work, and then also indoors versus outdoors. It's sometimes difficult to tell whether somebody who's reporting problems with house dust exposure, such as vacuuming, is causing or having problems on the basis of an allergic or non-allergic irritant basis, but these are all things that we should be asking about. I do think it's helpful to ask if people are better on vacations away from pets. We have, particularly in older age groups, a problem of gustatory rhinitis, where people have nasal symptoms in association with eating. And there are subsets of patients, of course, who can have problems with rhinitis from aspirin and NSAIDs, and also for those that may be more pediatric oriented, where ACE inhibitors aren't very frequently used. In adults, we have to be more mindful that ACE inhibitors can cause rhinitis symptoms even in the absence of the more commonly appreciated ACE inhibitor-induced cough. People can often respond well by a switch of from ACE inhibitors to other agents, including ARBs. Other parts of the history that can be useful are whether there's shifting congestion. We know that there is a cyclic response, generally every 4 to 6 hours, where one side of the nose versus the other will preferentially get blood flow. And that nasal cycling is actually probably a good thing, indicating you don't have some unilateral anatomic cause for congestion. Ask, of course, about whether there's been previous response to medications or lack thereof. That being said, ask people, yeah, you might have tried nose sprays, but like how long did you try them for before you gave up on them? Also be mindful that there are some people who can have a very acute illness with a respiratory infection, develop some ongoing rhinosinusitis, and they will have some persistent nasal symptoms with other symptoms, including headache. And that's actually what set them off. So if there's a very sudden, all-at-once onset of nasal symptoms, keep that as a differential consideration. And then we do have to be mindful of coexisting conditions such as asthma, sleep apnea, and acid reflux, which can be causing problems involving the nose. When you do physical exam, there frankly is no great pathognomonic finding that distinguishes allergic versus non-allergic versus infectious. I mean, something that looks like purulent drainage can be present in all of them, actually. You do want to, of course, look to see whether there's significant nasal septal deviation. You want to make sure that, to begin with, there's no nasal septal perforation, since that's something over a period of time that you have to be monitoring for, particularly with nasal corticosteroids. And then relative to nasal valve collapse, it's a pretty simple thing to do, where you push on one side of a patient's nose, and then on the contralateral side, laterally pull the patient's cheek. And if that makes a big difference on how they can breathe through that nose, that suggests nasal valve collapse, which something that a ear, nose, and throat colleague would best further evaluate. Of course, look at whether the turbinates appear to be swollen. Sometimes it's a question about, are they so swollen you can even get nasal sprays up there or not? That may also indicate a need for a short-term nasal decongestant spray to be given shortly before you would try, for instance, a nasal corticosteroid or nasal antihistamine. I've already mentioned that in some cases, inferior turbinate reductions may be quite useful. Look for nasal polyps. Here's a picture out of Middleton's that shows the kind of translucent character of nasal polyps higher up into the nose. Look at the eyes, the ears, the oropharynx, and of course, there is a high prevalence of concomitant asthma in many patients with rhinitis, so listen to the lungs as well. Specific IgE determination can be performed either by in vitro blood testing or skin testing, and it does help select what would be the appropriate pharmacotherapeutic options, because we know some treatments for rhinitis don't do anything for allergic rhinitis or for non-allergic rhinitis. And then, of course, you can identify specific allergens that are responsible for symptoms that can lead to focused allergen avoidance measures, or when appropriate, help you prescribe targeted allergen immunotherapy. One thing we really did emphasize was that the clinician should not be performing food allergy testing in the routine evaluation of a patient who's presenting with allergic rhinitis. We went through at some length demonstrating there's just not value for doing this, and in fact, it was a unanimous vote by both the working group and the overseeing joint task force that recommended against routine use of food allergy testing. I mean, we do have, of course, gustatory rhinitis, where more commonly people are presenting with rhinorrhea, although sometimes it can be congestion after the ingestion of food, and that's thought to be a neurologic reflex. But talking about IgE-mediated food allergy and where there could be some nasal symptoms, I mean, except for maybe oral allergy syndrome, there really is no evidence of IgE-mediated food-induced rhinitis symptoms without the presence of anaphylaxis, where people are getting multi-system involvement. In terms of treatment selection, a lot of this is, well, it's very thoughtful. A lot of things can go into the decision. And one concept that comes up is the amount of severity, the degree of severity of symptoms, and also whether people are having intermittent versus persistent symptoms. Now, in terms of the big picture, of course, we are looking at the triad of avoidance and environmental control, pharmacologic therapy, and allergen immunotherapy. The parameter focused mostly on pharmacologic therapy, but we don't want to forget the other strategies that are important. I do want to acquaint you a bit with the concept of intermittent and persistent. Now, I think, you know, the formal definition is as stated here. This is the allergic rhinitis in asthma ARIA definition of intermittent being symptoms present less than 4 days a week or persisting for less than 4 consecutive weeks at a time, versus persistent, where symptoms were present for 4 or more days per week and persisting for more than 4 consecutive weeks. We in the U.S. still use seasonal and perennial rhinitis, with the underlying cause in more temperate regions of the U.S. anyway, that seasonal rhinitis tends to be pollen caused, whereas perennial tends to be non-pollen allergens. The reality is life is always so simple and several things can be going on. And of course, you could have year-round non-allergic rhinitis with some seasonal allergic rhinitis to pollens overlay. Severity is a concept that we do use to help direct therapy, so I wanted to briefly go over that. This was first defined by the ARIA guidelines as mild versus moderate to severe, with the idea being that in terms of symptoms, mild would be where you do not have any sleep disturbance, impairment of daily activities, impairment of work or school, or very bothersome symptoms, whereas moderate severe is where you start getting into that. And ARIA had more recently developed a severity score based on a visual analog scale, which I won't go through here, although there's a 10-point scale that's used. But you should also probably be aware, if nothing else, about the total nasal symptom score that is used in a lot of clinical trials for treatments for rhinitis. And essentially, a total nasal symptom score can have a maximum score of 12, and you get up to 3 points of severity for 4 domains of watery rhinorrhea, sneezing, nasal congestion, or pruritus. Most studies, by the way, would want someone, a research participant, to have symptoms somewhere in the, well, 5 to 6 range anyway, so you have enough of a signal of improvement that you can tell whether medication is having some benefit. And then you can also throw in symptoms of allergic conjunctivitis with some of these scoring scales. Just be aware of that is something that not only could be theoretically used in clinic, although there are other surveys that can be used, but this is something that underlies a lot of the clinical trials that are used for approval of medications for treatment of allergic rhinitis. So how do you end up choosing medications, and what has changed perhaps over the years? Well, there are some general considerations. One is you want to decide, okay, are you dealing with allergic or non-allergic or mixed rhinitis? Again, some medicines don't do anything for non-allergic rhinitis. In terms of severity, the intranasal corticosteroids are clearly for allergic rhinitis more effective than oral antihistamines or oral leukotriene receptor antagonists. If there are fairly frequent symptoms, or if they're intermittent, you might want to consider use of rapid onset agents. And I've got some information coming up about how quickly different agents can have a clinical benefit. On the other hand, if somebody is having ongoing persistent symptoms, but you have an agent that, let's say, over a week or two will ultimately lead to much better control, might be worth considering of putting the patient on that to achieve better control than a shorter onset action agent that may not be as effective with longer term use. If you're talking about nasal congestion, you, for instance, would be thinking more about using a nasal corticosteroid than an oral antihistamine or leukotriene receptor antagonist. And even though it's not commonly marketed, remember that for residual rhinorrhea or solely rhinorrhea, nasal ipratropium is a good consideration. Another question would be, okay, if you've got somebody with seasonal rhinitis, for instance, who starts having problems in a rather predictable way in the spring, consider starting agents even a bit before the season gets up and running to prevent symptoms from developing to any degree of severity. There are episodic environmental exposures. Let's say somebody is going over to a home with pets, and otherwise they're not having exposure to them. There are some pre-exposure regimens that could be used. For instance, nasal cromolyn, which otherwise has to be used very frequently if it's going to be of any value. That can be useful taken just prior to allergen exposure with an episodic exposure. And then, for instance, a nasal antihistamine with a quick onset of action may be also useful in that type of a context. The reality is nasal sprays are not well accepted by, well, not only just kids, but also adults. That must play into patient acceptance. And then we do have some information that we emphasize about avoiding first-generation antihistamines in more senior patients, in part because of the increased risk of dementia, but also potentially risk for falls. And then oral decongestants may be more problematic in senior patients. I mean, ultimately, there's a lot of shared decision-making going on between patient and caregiver preference, cost, of course, and then a risk-benefit assessment. So some summary considerations would be that intranasal corticosteroids are generally the most effective medications as monotherapy for allergic rhinitis and are also a first-line treatment for non-allergic rhinitis. Some medications can be effective in either allergic or non-allergic rhinitis, but notably, second-generation oral antihistamines and oral antileukotrienes and nasal cromolyn don't have effectiveness for non-allergic rhinitis. They're really only for allergic rhinitis. You can use combination therapy when either monotherapy is not working or right off front, right up at presentation, patients are having more severe symptoms. But you have to realize that just adding medications together doesn't necessarily mean they're going to be better than monotherapy, and I'll give you an example of that. When we give patients intranasal preparations, we really should be instructing them on how to properly spray the nose sprays immediately towards the septum. Offer them the so-called nose-to-toes technique, where after applying with the patient having the head in an upright position, then dipping down for 20 seconds or so, to then, after they get up, reduce the amount of drippage down the back of the throat or down the front of the nose. We do have to be mindful that when we're giving intranasal preparations, there should be periodic examination of the septum to make sure there are no mucosal erosions. And again, for episodic environmental rhinitis or intermittent rhinitis, one might choose a medication with a more rapid onset of action. Speaking of which, we quite diligently tried to go through and see what were the studies of onset of action of the different medication classes. One column here is the estimated onset of the start of benefit. Now, that doesn't mean you're going to be getting up to full benefit, but for instance, if you're looking at a combination of azolastine and fluticasone, that can have a very rapid onset of action within 5 minutes. Intranasal decongestants are also quick acting, generally within 10 minutes. Intranasal antihistamines can kick in within 15 to 30 minutes. Ipratropium also has very rapid onset of action within about 15 minutes. Oral antihistamines can vary a bit, and the study design can alter things, but you're talking a slower onset of action, maybe a minute, or excuse me, an hour or so. And then when you have combinations of oral antihistamines with pseudoephedrine, the onset can be within 30 minutes or so. There are different study designs that are used to determine this, whether there's an environmental exposure unit where people are actually put into special rooms that have allergen exposures versus so-called park settings where they go out into the wild and have natural exposure. But also note that maximum effect can take much, much longer. And if we're looking, for instance, at intranasal corticosteroids, okay, you can see with some studies that you're getting benefits within a number of hours, but the maximal effect for nasal corticosteroids is really 2 to 4 weeks out. So anyway, this can be useful for making decisions about whether a medication might be better suited for a rapid onset in a intermittent or episodic fashion. So let's go to a question about a 37-year-old man with moderately severe allergic rhinitis who has improved but has had inadequate control taking an intranasal corticosteroid. What would be the preferred next step? Would you add an oral antihistamine? Would you switch to an intranasal antihistamine? Or would you add an intranasal antihistamine? You can argue this, but the preferred recommendation would be to add an intranasal antihistamine and not add an oral antihistamine, even though that is a very frequently used practice. Now, there's a fair amount of discussion in the parameter about the evidence for this, but the bottom line is the certainty of evidence for using an oral antihistamine plus a nasal corticosteroid is very low. Can it possibly help? Yes, but the usual approach of adding an oral antihistamine plus a nasal corticosteroid really does not demonstrate benefit, at least up front, versus monotherapy with an intranasal corticosteroid. So that does bring in the question about use of nasal corticosteroids along with intranasal antihistamines. And essentially that combination is recommended for not only allergic rhinitis, seasonal and perennial allergic rhinitis, SAR and PAR, but also for non-allergic rhinitis. So I've sort of distilled a number of the key recommendations. So for allergic, seasonal allergic rhinitis treatment initially, we suggested that the clinician consider the combo of those two types of nose sprays for patients with more moderate to severe nasal symptoms. And you'll note in patients age greater than 12, An overall problem that we had looking at all the data was, if you're looking at data in kids versus adults, the data in kids is not nearly as robust. There just aren't that many studies in a comparative way. So in many of these recommendations, we are stipulating that it's for the ages for which there's been good studies in large numbers, greater than age 12. But that's not to say that these approaches can't be used in kids. But that's really just a reality check as to what the studies actually allow us to say or not. Also, moving down, that if you have some patient who is resistant to monotherapy with allergic rhinitis, that would be another scenario where you would add the intranasal corticosteroid and intranasal antihistamine together. For non-allergic rhinitis, we did mention that versus some previous iterations of the practice parameter, there was more and more information showing that the combination of the nasal corticosteroid and nasal antihistamine can lead to better control of non-allergic rhinitis. In terms of first-line monotherapy for non-allergic rhinitis, you can offer either intranasal antihistamine or intranasal corticosteroid. The evidence is actually quite secure for benefit from intranasal antihistamine. So, although oral antihistamines for non-allergic rhinitis are not recommended, intranasal antihistamines certainly are. We did spend some considerable time deliberating about use of first-generation oral antihistamine, so things like chlorpheniramine or diphenhydramine in allergic rhinitis. And some members of the work group even said, well, if you gave it at bedtime, then the sedation effects in the morning are not going to be that great. And so if you had somebody who's got a lot of rhinorrhea and you're trying to take advantage of the anticholinergic side effects of a first-generation antihistamine, hey, give it to them at bedtime. But overall, the concern of the task force and the work group was that these agents can have a number of side effects that you have to be worried about. And it's not only potential sedation at bedtime, but many of these agents like chlorpheniramine, they have effects that go on way beyond 8-12 hours. And then you could have somebody who's having thinking impairment, driving impairment the next day. Also importantly, poor sleep quality. There's evidence that, like with diphenhydramine, you can get some sleep, but the sleep architecture is disturbed. People don't have the good REM sleep that they need. And then, of course, you do have to be mindful of anticholinergic mediated symptoms, urinary retention, particularly in older men. And then there is a continuing signal of concern about ongoing use of first-generation antihistamines and increased risk of dementia. So that's where we really made the decision that we would recommend against the general use of first-generation oral antihistamines in patients. The guideline came out in 2020, and actually the final version had gone into JACI in February of 2020. And then in March of 2020, the FDA issued its black box warning about montelukast being associated with serious neuropsychiatric events and suicidal thoughts and actions. We got the comments back from the reviewers and made major changes in algorithms and recommendations so that we really recommend that montelukast should only be used in patients who have an inadequate response or intolerance to alternative therapies. All right, next question. Intranasal decongestant use should be limited to about 5 days duration. Your choices are true, false, or it depends. So as you might guess, it depends. We do keep to the traditional recommendations that's consistent with product labeling that nasal decongestant should be used for the short term only in general. And we actually state that there was several summary statements, including 17 down there, that particularly in patients with more severe mucosal edema, you could use a nasal decongestant for up to 5 days of use, beyond which the concern is the development of rebound nasal congestion and rhinitis medicamentosa. However, we also did look at data that concomitant administration with nasal corticosteroid can allow patients to tolerate better nasal decongestants without developing rhinitis medicamentosa. And particularly down at the bottom, we looked at studies that reported that there was no rhinitis medicamentosa that occurred with 2 to 4 weeks of intranasal decongestant use, so long as there was concomitant intranasal corticosteroid administration. The parameter also featured the use of algorithms that were really a passion that we had to try to distill all sorts of scientific evidence and expert opinion. They were developed to assist the clinician in selecting preferred monotherapy and determine when to use specific agents in combination of therapy. These are guides. They can't account for variable patient adherence in real life experience, but here's an example of one of the algorithms. And you might look at it first and say, oh my gosh, that's an awful lot of detail. But it's there for a reason, particularly for those of us that are to be expert treaters, if you will, caregivers for rhinitis. So this particular algorithm is looking at patients with persistent allergic rhinitis, and it divides patients with milder symptoms versus more moderate to severe symptoms. And basically it goes through a kind of a hierarchy of preference. There's all sorts of footnotes as to why these things might be considered. And then the symptoms don't respond, what you end up doing to it. So just as a little bit of a blow up, for instance, with milder symptoms, we put in different treatment options, including the onset of action. And then, we have to make the recognition that this is based on expert opinion. And you should also be mindful whenever you step up about ultimately trying to step down. Again, I'm just sort of showing these to you so you see what's in there, but there's a lot of thought, and there are footnotes that actually have a lot of detail in there about why we made the decisions or the recommendations that we did. So don't just skip over the footnotes. It's important. Considerations in particular subpopulations. Well, first of all, in kids, again, as I've already said, controlled trials or real-world experience that have looked at the comparative effectiveness, acceptance, and adherence of medicines are more limited in children than in adults. So we didn't actually go ahead and try to develop algorithms for treatment of children. We also know that adherence to nasal sprays may be a greater issue, particularly in younger children. And we do, though, discuss, there's a whole section on pediatric treatment. We discussed different options, but we felt we couldn't be as, directive about our recommendations for treating kids as we could for adults. Pregnancy is an important consideration for reasons of safety. Generally speaking, what you should be aware of is the safety data for intranasal corticosteroids is generally quite good, with an exception of triamcinolone, which was associated with a higher rate of congenital respiratory defects in a large Canadian prospective cohort study. You couldn't rule out a chance finding, but looking at the data, the work group and the task force felt that if there were some significant signals coming up, that should be entering into our decision making. Generally, there is relatively little data about intranasal antihistamines in pregnancy. However, there's really pretty good data about oral antihistamines. There had been originally some concerns about certain antihistamines having some risk of congenital defects, but larger studies did not show any issues with that. But this brings up another question. Intranasal decongestants are safe for use during pregnancy. True or false? I mean, you might think, well, it's a nasal preparation. There's not that much absorption, is there? But there's actually cause for concern. So this is a verbatim extract of the text looking at oral and intranasal decongestant safety. And basically there's uncertainty about it. There was a large study called the Sloan Birth Defect Study that confirmed an association between oral pseudoephedrine and gastroschisis. The same review also found that topical decongestants such as oxymetazoline, when used in the first trimester, had an association with gastroschisis and pyloric stenosis. And there were some issues in the second trimester with the renal collecting system anomalies. Well, we're not using really phenylephrine anymore in general because the recent FDA advisory meeting 2 years back I was part of, and then the removal of the market from many of the preparations that have phenylephrine. But still, the bottom line is that with early trimesters of pregnancy, it's better to stay away from decongestants, whether they are oral or nasal. We also have to be mindful that in terms of oral decongestants, they have to be used with caution in older adults and children for a whole variety of reasons that are listed there. And I've already made this statement, but it bears emphasis that for both non-allergic rhinitis and allergic rhinitis, the combo of a nasal corticosteroid and a nasal antihistamine is recommended. So what are some of the key takeaways from the rhinitis parameter? Don't do food allergy testing. Don't use certain combinations such as an oral antihistamine with an intranasal corticosteroid, thinking that's got a very high likelihood of being more effective than intranasal corticosteroid monotherapy. Now, that being said, there is another guideline under development, an update of the allergic rhinitis in asthma guidelines. I'm the U.S. representative to that. There are data that are being generated by a app that rhinitis patients can enter data for, and people can enter into what medicines they're taking, how they are doing with their symptoms. And so on the question about are there patients who are inputting data thinking that an oral antihistamine can help them with symptoms on top of, let's say, an intranasal corticosteroid, there are some data. I mean, one of the questions would be, could this in some cases be a placebo effect? Is it a real effect? All to say that depending on how we're going to be looking at the data, there may be some nuance of the treatment of that particular statement. Back to point 3, montelukast should only be used for allergic rhinitis in patients who have an inadequate response or intolerance to alternative therapies. And then again, another helpful thing, I mean, oftentimes we do see people coming in who, well, they're miserable. They've been maybe using some nasal decongestants more than we would like them to. But at least when you are using concomitant nasal corticosteroids with a nasal decongestant for a number of weeks, you probably can avoid getting into too much trouble. Now, that's, of course, a different story than if somebody's already been using an intranasal decongestant without anything else for the last couple of years, and you're trying to wean them off of that. You may have to use not only intranasal corticosteroids and or nasal antihistamines, but potentially oral corticosteroids as well. So that concludes my formal presentation. I'd be delighted to entertain any questions that you might have.